In clinical practice, it is very common to come across patients with malabsorption. So, in this lecture, my goal is to make you understand the normal process of digestion and absorption step by step, and it will make it easy for you to understand any abnormality in this process and how can it affect a patient clinically. The first is mechanical processing of food, which is by chewing, and then peristalsis. Then digestion within lumen, which is by gastric acid, intestinal enzymes, pancreatic juices, and bile. Then next step is digestion by enzymes which are present in luminal brush border. After this, there is absorption from lumen to the mucosal epithelium, and this is followed by processing within mucosal cells. And finally, transportation into blood and lymph, through which the absorbed substances reach liver and systemic circulation respectively. Keep this simple diagram in mind where first luminal enzymes act on food, followed by processing at brush border, and later within mucosal cells, and finally removed by lymph or blood. After understanding the normal digestion and absorption, let's come back to our main topic, and that is malabsorption. The prefix mal means something wrong. So the word malabsorption means there is something wrong with enzymatic splitting and absorption of food within gastrointestinal tract. We know that our food contains three main energy sources, that are fats, carbohydrates, and proteins, plus vitamins, iron, calcium, magnesium, and some other elements. All of these have to be processed and absorbed before reaching blood, right? Now, different constituents of food have different sites of absorption, which mainly depends on two factors. Number one, the number and duration of preceding steps of processing and splitting. And number two, the provision of specific mechanism of absorption in different segments of gastrointestinal tract. This is the reason that monosaccharides, which are quite simple in structure, such as glucose and galactose, are absorbed at the beginning of the duodenum, and disaccharides must first be split by enzymes of brush border, and polysaccharides, which are complex of all, like proteins and fat, must first come into contact with pancreatic juice, so they are absorbed in jejunum. Now let us come back to steps of digestion and see which specific defect causes which specific disease. Let us focus on luminal digestion first. We'll start with stomach. After gastric resection or vagotomy, the stimulation of enteral hormone, for example CCK, is reduced, the main function of which is to slow down gastric emptying, and less synchronization of release of acid-rich pulpy fluid coming from stomach called chyme with pancreatic secretion, gallbladder emptying, and cholerasis, which means secretion of bile by liver into gallbladder. All is disturbed. Also, passage of food through small intestine is accelerated, which makes pH in duodenal lumen too acidic, leading to interference with digestive process. What happens is that acidic fluid coming from stomach causes inactivation of enzymes and bile salt precipitation. The next cause could be gastrinoma. Now, what is gastrinoma? It is gastrin secreting tumor of stomach which leads to production of too much of gastric acid and lowers down the pH. And in addition to Zollinger-Ellison syndrome, it causes malabsorption by same mechanism as I described above. Next very important organ which could be culprit of malabsorption is pancreas. It performs two vital exocrine functions which are helpful in digestion. Number one, it produces important enzymes like lipase, colipase, trypsin, chymotrypsin, amylase. And number two, it produces bicarbonate, which is needed to neutralize the acidic secretions coming down from stomach. So loss of these two important functions can lead to what? Malabsorption. Now, can you name some of the pancreatic diseases that could lead to loss of these functions? Yes, chronic pancreatitis, carcinoma of pancreas, cystic fibrosis, and dissection of pancreas. Now let's come down to intestines. Do you know about atrophic gastritis? It is chronic inflammation of gastric mucosa leading to destruction of glandular cells, which lead to impaired secretion of essential substances from stomach, and one of them is hydrochloric acid. We call it hypochlorhydria or achlorhydria. Normally, this acid is very important for intestines because it acts as an antiseptic, means killing of bacteria. But now, due to achlorhydria, there are more chances of colonization of small intestine with bacteria. As a result, there are plenty of organisms in intestine, and what these creatures do? They deconjugate bile salts and hence making them inefficient. And they split binding between intrinsic factor and cobalamin. The resulting cobalamin malabsorption leads to cobalamin deficiency. After luminal digestion, let us see mucosal digestion abnormalities. Some people lack brush-bordered disaccharidases, and one of them is lactase, which splits lactose into glucose and galactose. What do you think it can lead to? Yes, such patients develop intolerance to milk and other lactose-containing foods. Also, at brush borders, sometimes there is defect in specific carriers which can cause specific malabsorption. For example, Hartnup disease, in which there is specific carrier defect for certain neutral amino acids. And cystinuria, there is cysteine and some cationic amino acid carrier defects. But more common than brush border enzymes or carrier defects are global mucosal defects, which happens in diffuse mucosal diseases. And they are celiac disease, tropical sprue, Crohn's disease, Whipple's disease, AIDS, infections, for example, with salmonella, radiation enteritis, and after resection of large portions of small intestine. After food is absorbed, it is processed within mucosal cells. So we are going to discuss abnormalities here. Now, next step is processing within mucosal cells. The defect here mostly leads to fat malabsorption. You know that chylomicrons are structures which are produced in enterocytes for transportation of dietary triglycerides and cholesterol. The disturbance of this step happens in an inherited disease called A-beta lipoproteinemia, which is characterized by fat malabsorption, spinocerebellar degeneration, and pigment retinopathy. Now, mucosal processing is done, and we are at our last step, that is removal of absorbed nutrients either by lymphatics or blood. Remember that these chylomicrons we just studied about are absorbed and transported by lymphatics, and blockage in lymphatic vessels like in lymphangiectasias and lymphomas can contribute to fat malabsorption. Similarly, if blood flow through intestines is disturbed due to vasculitis or any other cause of ischemia, it can lead to malabsorption of nutrients transported by blood. In the end, we will try to do correlation of malabsorption of different food constituents with clinical condition caused. The three main constituents of food are proteins, fats, and carbohydrates. You must have heard that proteins are building blocks of our body. So the deficiency of proteins, called hypoproteinemia, leads to muscular atrophy, weight loss, and edema. Malabsorption of fat is characterized by fatty stools or steatorrhea, and it can lead to weight loss from lack of these high-calorie components of food. When carbohydrates are malabsorbed, some of them are metabolized into short-chain fatty acids and gases like carbon dioxide and hydrogen, which leads to distension and flatulence. And if more than 80 grams per day of carbohydrates fail to be absorbed, osmosis-induced watery diarrhea occurs. Similarly, malabsorption of fat-soluble vitamins and micronutrients can also lead to corresponding consequences. For example, vitamin A deficiency can lead to hyperkeratosis and night blindness. Vitamin D deficiency can cause osteomalacia in adults and rickets in children. Vitamin K deficiency can cause bleeding. Then malabsorption of water-soluble vitamins like vitamin B12 and folate can lead to macrocytic anemia, glossitis, aphthous ulcers, and neurological defects due to nerve degeneration. Iron malabsorption can lead to hyperchromic anemia. A number of drugs also cause malabsorption by different mechanisms. So, which are these drugs? Colchicine. It inhibits the division of Krebs cells and disaccharidases. Then neomycin and similar antibiotics, in addition to causing inhibition of division of Krebs cells and disaccharidases, causes precipitation of bile salts and micellar fatty acids. Methotrexate inhibits folate absorption, cholestyramine binds bile salts, and laxatives, if excessively used, can also lead to malabsorption. Alcohol, we all know, causes malabsorption not only by causing pancreatic insufficiency but also chronic liver diseases. So this was all about malabsorption. One tip in the end is that if you will try to understand it according to malfunction of anatomical side, there is less likely that you will miss any reason of malabsorption in patients.